So last week we talked about heredity issues, genetics, and conception, and now we're talking about birth and the newborns. We're talking about the childbearing process, and then also what children are like when they are first born, and some parental issues as well. So I really like this quote from our textbook: customs surrounding childbirth, and I actually like to add, and the postpartum period, reflect a culture's beliefs, values, and resources. So I put a couple different pictures of newborns with their fathers, mothers, grandparents, different cultures, different places in the world, because who we are as a culture really impacts how we take care of mothers who have just delivered, and then newborns as well. It also plays into our resources as well, what our healthcare access looks like, and the healthcare system that we have built up around newborns and mothers. A little bit of the things we'll talk about: the birth process, the postpartum period, labor and birth complications, how infants are as newborns, how they are with their parents, and how they attach and bond. We'll talk about postpartum depression both in this lecture, and that'll also be your assignment for this week, and then some disparities in birth outcomes. So certain races and cultures have different disparities in birth outcomes and ways that we can change that. So like I said before, customs surrounding childbirth reflect a belief, values, and resources. And then also how we treat people in those postpartum periods. So in the 6, 8 weeks, or 12 weeks after someone delivers, how do we care for their newborns, for that mother, for the father, and for the family that is welcoming a new child into their family, or possibly putting them up for adoption and fostering and adopting. A newborn is born into a very specific environment in a specific place and time, and they immediately begin to change and adapt to the environment that they are born into. And then they also are that environment adapts around them. So who my great-grandmother was her name is Cora, and that's what I ended up naming my third daughter. So who my great-grandmother was, born in 1899 in Tennessee. She lived as a coal miner's wife. She farmed. I have chickens, so I guess I'm not that far off. But she had chickens, she had goats, she had cows. She milked the cows for milk every morning. She only had a 6th grade education. I have a master's degree. So how she raised her children, so how she raised my grandfather in the Depression, is really different than how I'm raising my daughter, Cora, who was born in 2016 in Southern California. So even within families, our generation, where the place where we're born, Tennessee is really different than Southern California. 2016 is really different than the Great Depression. So those environments shaped my great-grandmother and my grandfather and how he was raised, and now who I am and who my parents are now shaping how I am raising my own daughters in the 2000s in Southern California. Real fast though, the birth process, or labor and delivery, the funny thing is that we don't really know what triggers it. So if you've ever been around a pregnant woman who's 39, 40, 41 weeks pregnant, they're really anxious to have the baby. They want to know when. They're getting a little bit cranky. It's really hard. The baby's very heavy in your body. They can be really large at that point. My children were only, my youngest daughter was 8 pounds, but I still felt really, really big at that point. And with my twins, I was humongous. So we don't know why they go into process, but we know that there's some kind of hormonal changes going on, especially in those last 2 weeks of labor. There's hormones, the placenta, then the kind of protective organ around the baby, the placenta, releases some kind of hormones. And we know that there is a decline in progesterone, and then we know that cortisol, which is kind of our stress hormone, starts to go up, and so does estrogen in preparation for having this baby come out. So we know that there's some hormonal issues, and they're theorizing that it has something to do with our metabolism as well, that we can't continue to take in enough food in order to support that baby any longer. Our bodies just can't handle it anymore. So we don't know why it happens. You can be induced, which is kind of a chemical process that can start in the hospital. And that can happen if there's complications with the baby or with the mother, if the blood pressure is getting too high, there's issues with the placenta, will then choose to take the child out early, either through a C-section where they cut through the mother's body into her cervix and take the baby out, into her uterus and take the baby out, or you can induce it by giving a cocktail of drugs and hormones that make the labor process start. No matter how it kind of happens, a child comes out at the end, but in a natural or vaginal delivery, there's dilation. So you're going from the cervix not being open all the way into 10 centimeters so that, a baby's gigantic head can come out. And then the baby descends and emerges from the birth canal. And then at the very end is the expulsion of the placenta. That's the one I've always forgotten about in all of my childbirths. I think, oh, I have my baby, she's on my chest, I love her so much. And then they're like, okay, you need to push again. And it's like, oh God, I forgot about the placenta. So that is, and I've got this kind of picture here, this is how, the kind of babies come out of the mother or the person who has delivered. We have these kind of societal ideas of childbirth, and it really depends on your culture, your race, your access to healthcare, and it's really changed throughout history. So that's why I have some images of different ways that women have delivered throughout history, and then different ways in different cultures that we kind of see childbirth. So I was just reading an article about in Haiti, they are putting together money to have solar-powered birth kits for midwives. So midwives who are in super, super rural areas who might need to be delivering at night or in buildings that don't have lights or electricity, you have solar powered kits so that you have the light that you need in order to deliver the baby. And then also it's solar powered ways to heat up water so that you can sanitize things, sanitize the equipment that you have, like scissors in order to cut the umbilical cord, things like that. So that's definitely something where access to healthcare comes into play. How we deliver mostly in this United States is in hospitals. It's quite medicalized. We have all the access to things that we need in order to make sure that women and children survive the birth process. But in other places in the world, like Papua New Guinea has one of the worst infant mortality rates. I think it's 1 in 7 women die in childbirth. There's very, very little access to healthcare, prenatal healthcare at all. And then when they deliver most like outside of their huts. They're asked to leave where they live. They go out into the jungle and they deliver, and they're typically back to work within 2 to 3 days, or even that next day, back within their tribal kind of society, working right away. So they actually have 1 in 7 women die in childbirth, and their infant mortality rate is quite high as well. For a variety of reasons, a big part of that is access to healthcare. So if there was an issue in healthcare, being very far away from any kind of hospitals or ways that you can get help definitely plays into the mortality rate of these mothers. But culture as well plays into it. Even places that have access to healthcare, people might choose to deliver in different kinds of ways. It's definitely changed through history as well. So talking about that, we have stillbirths and neonatal deaths. So a stillbirth is a sudden death of the fetus after 20 weeks. So anything before 20 weeks is considered a miscarriage. Most miscarriages happen within the first 12 weeks, and I had a miscarriage where the fetus stopped developing at 10 weeks, and we discovered at 12 weeks, and I had a surgery in order to take that fetus out of my body, since it wasn't coming out on its own. But if I was to have one after 20 weeks, that's considered a stillbirth. Sometimes it's discovered during prenatal care. You'll go in for a routine visit and the fetus will have stopped developing, or sometimes during birth and delivery, a fetus will die. The cord will be wrapped around their neck. There'll be an issue with the placenta, something like that. We have, and this is why healthcare is so important, through ultrasounds, through fetal monitoring. That's where you go in and they kind of put this machine on your belly. It's very small, it's about that big, and it measures the heart rate of the child and the contractions that are happening, and then prenatal surgeries as well. So C-sections, amnios, where they can take fetal liquids and see how they're doing, have led to the stillbirth rates falling very significantly since 1990. So through our access to these really great healthcare issues, and innovations, we have actually been able to make sure that that stillbirth rate continues to fall. There's also old school methods that are still being used, such as a kick count. So in your third trimester every night, typically you count how many times the child kicks. So if there's a decrease in that kind of fetal movement and fetal behavior, then you go to your doctor and they will monitor the child and then make the decision, do we need to take the child out? Do we need to leave the child in? That type of situation. So it's quite old school. You're just counting, kicks to see how active your child is, but that also leads to a decrease in the stillbirth rate as well. Then we have the stillbirth, which is in utero, so inside your body the child dies. And then a neonatal death is any death of a child who has been born but dies within those first 28 days of life. I've gone through this personally. I had a close friend whose child had significant muscular issues. He passed away when he was 2 weeks old, and it was really, really heartbreaking. Some of the complications that can lead to a child dying in the first 28 days, so that neonatal mortality, is a very low birth weight and a birth weight that's small for the gestational age. This can mean that something else is going on with the child. So if you were 40 or 41 weeks pregnant when you delivered and the child came out and they were 3 or 4 pounds, that's really an unusual weight. It's very, very small for having that long of a gestation. Other reasons that a child can pass away is typically a lot of it is the preterm birth complications, and that's that blue area, and that's 35%. So that's like if there's an issue with the placenta, or the cord is wrapped around the neck, or the heart rate starts to go down while you're delivering. Then there's the interpartum related complications. So those are things that are happening right before the birth happens or right after the birth. Sepsis is that green, and those are group B or infections or strep infections. And that is something that you're also tested for in your third trimester as well, to make sure that you don't have this infection and you don't pass it on to your child. And that's why it's so important to access healthcare when you're pregnant or about to deliver, is to make sure that you don't have group B or a certain strep infection that you could pass on unknowingly to your child when you deliver to them. Then soon after they're born, this is the pneumonia, the RSV, the whooping cough, and the flu. And that's why it's so important that the people around a child are immunized. So when I had my twins, I got my whooping cough, my husband got his whooping cough, my parents got their whooping cough, and my in-laws got their whooping cough as well, so that we would make sure that we didn't have it. I got it pregnant as well, but we could protect the child who we couldn't give that immunization to as soon as they were born. Then there's some other things as well, but they're much smaller. So these are just some of the things that can cause that neonatal mortality, or which is at birth which is in the first 28 days. Some other complications that might not lead to death are jaundice. So that's when the baby is like super orange or yellow, and this is just an issue with their liver and being able to kind of process things. It also has to do with the mother and the child's blood type as well. All of my children have been jaundiced, and we've spent anywhere from 3 to 7 days in the hospital because they need to be under the light blanket. So you put them in a box, or you hold them on a light blanket that puts UV light into their body, or you can, if you were in a developing country, you can put them outside. But what it does is it kind of stimulates the liver to break down some of the enzymes that might be in a child's blood. But that's one complication. The low birth weight that I talked about in the gestational age are also labor complications that we can solve really easily with access to healthcare. Another issue with birth is prematurity. So if you get to 24 weeks pregnant, that's what they call viability. So if the child was to be born 24 weeks and after, they would have a really good shot at being born. We want them to stay in as long as possible. We want them to stay to 37 weeks. So that's like, we want them to be in like 8 or 9 months to give them the best chance of developing in utero. So anything before 37 weeks is considered premature, but they can come anytime after 24 and have a really good shot at making it. They will spend time in the NICU, which is the neonatal intensive care unit, and there's different types of NICUs in different types of hospitals. So Tri-City here in Oceanside has a level 3 NICU, so does Mary Birch, and I think Children's Hospital as well. And that's where they care for premature babies, or babies that are just born that are very, very, very sick. And put this picture in. It's a little bit grainy, but it shows how small these children are. So that little green thing is about that big. So the baby's head is about that big. So it's a really, really small infant. With the prematurity, and that's why I bring it up in a child development class, is there's definitely an added risk for developmental delays. So in my job as an early interventionist, I work a lot with children who are born premature. So 25, 26, 27, all the way up to 32 weeks, you're most likely going to have some added risk for developmental delays. This can be cognitive, physical, language, or social and emotional. So in any of those areas of domains, you can have a developmental delay. And that would make sure, that then means that you can get services through regional center, which is with the county, and that's what I do, or First Five, or you can get therapy through your doctor. And these services are usually put in place as soon as we know that the child is having any delays, so that they can make up for that prematurity. So by the time they're 3, 4, 5 and ready to go into more formal schooling, those delays have been bridged and the child is at the age that they should be. Some children will need additional health monitoring as well, and the areas that are typically affected when a child is born premature are the lungs. That's kind of one of the last systems to develop, so they need some additional help developing. The heart, a lot of times there can be heart surgeries as well. There can be bleeds on the brain which impact cognitive development, and then the eyes as well. That's one of the last systems to develop as well. That's why we want them to be gestating until they're 37, 38 weeks so that they can work on these systems. So that's a place where they would need additional health services and monitoring to make sure that they can bridge those gaps and reach their fullest potential. Some of the things that a child will go through as a newborn are some screenings. So typically there's an APGAR test, so as soon as you're born, we look at different types of what your skin looks like, how you're breathing, things like that, in order to determine if the child is going to need any medical support like oxygen, or they're going to be needed to take to the NICU, or a pediatrician is going to need to look at them right away. So it's just a little test that kind of indicates if the child's going to need some additional support, and it might also indicate that there's some brain damage, but not always. One of my twins had a very low APGAR test, and she has had no brain damage. She just came out a little bit kind of floppy because she's a twin and she was the second birth. And she was born 20 minutes after her twin, and we had to take her out kind of fast. And so she came out, I think, a little bit shell-shocked. So her APGAR was really low, and we did give her extra oxygen. She got rubbed down. They had a pediatric team come in and take a look at her, and she turns out she was fine. Then we also look at the Brazelton scale, and I only bring this up because it looks at a child's ability to use their reflexes, so kind of how they use their real kind of lizard reptile brain, how alert they are, and how their motor ability is. And I only bring this up because this is kind of how we assess really, really young infants. So if you're looking at a newborn, they don't do much. You know, they scream, they cry, that's how they communicate. They don't smile, they don't talk, they can't tell you what's wrong with them. So for intervention to see how a child is doing, we're looking at how alert they are, how they're kind of moving their body, and if their reflexes are still present. Then we also have screenings, and so that's well-child visits, which is from the American Academy of Pediatrics. So you take your child in a very set amount of time, and they look at the child in order to make sure that they are developmentally growing as they should. I think well-child visits are really, really important. I've taken all of my children, and I do it when I'm supposed to, because I have had them come back as needing support. So you would think somebody who's a child development instructor at a community college wouldn't need additional support, but I do. I had some concerns about language with my twins, and at the 18-month developmental check, it showed that they were a little bit behind. We got them 6 months of speech therapy in a little group. They kind of did this little baby class. It was adorable. We were able to bridge those gaps, and now their speech is really good. And it actually showed that one of them was having issues saying certain sounds, and so she did an additional 2 years of therapy, and now she's pronouncing all of the sounds as she's supposed to. So even as somebody in this field who might know a couple of things, I still use my well-child visits in order to make sure that their health is really good. So what they see, what they hear is really good. And then developmentally, so one of my well-child checks showed that one of my twins had hip dysplasia, and so we needed to put her in a brace. So it is showing us issues that the child might have with their health and with their development, and then gets them the appropriate services so that they can grow up to be really healthy. Some at-risk populations. So I talked earlier about there's disparities in our healthcare access and there's disparity in outcomes. So for our African-American populations and African-American mothers, there's a higher rate of stillbirth, of the children being born with a low birth weight. They're more likely to be premature, and they're more likely to die within the first year. And there's a lot of evidence and a lot of research showing these unfortunate statistics. We also know that some other at-risk populations are teenagers. First of all, if you're really, really young, like 13 or 14, your body's still growing. Your hips are not as wide as they probably should be. You don't have all of the body fat that you need in order to sustain yourself through a pregnancy and a child through a pregnancy. As our teenagers get older as well, their brain are still developing, and they're more likely to make some decisions about healthcare that are things that we wouldn't want them to do, like skipping prenatal appointments, not delivering at hospitals, hiding pregnancies. You hear those stories. I delivered at prom in the bathroom. That's because they're still really young. Their brains are still developing, and they might not be thinking about the child when they're making decisions about their lives. A multiple pregnancy. So for like me, I had twins. I was at a very high risk pregnancy. I spent a lot of my pregnancy in and out of hospitals, and I actually suffered some kind of life-threatening complications for myself at 32 weeks, but my twins and I made it through. And then if you're overweight and obese when you become pregnant, that can have some complications on the child, like developing gestational diabetes, which can lead to a larger child, and it can also have some complications with the birth process as well. Anybody who has prior medical complications, so if you've ever seen Steel Magnolias, it's a very old movie, if you probably haven't seen it, it's from the 80s, it's got Julia Roberts in it, but she has diabetes, and she, I was about to give you like a huge spoiler, but it's her dealing with the issues of having diabetes while pregnant. I totally almost gave that one away. So if you want to see it, I haven't given it away, but it's called Steel Magnolias, and it's with Julia Roberts. And then your socioeconomic status plays within it as well. So if you're homeless or even just couch surfing or drug exposed, so you're using drugs while pregnant, and that includes marijuana and smoking, that is going to impact your ability to use healthcare in order to kind of work with your drug abuse or provide prenatal care for your child. A low birth weight, so anything really under 7 pounds is associated with a lower socioeconomic status, the number of prior pregnancies you've had, the age of your mother, so if you're really young, 13 or 14, or if you're over 40 years old, your race, what kind of diet you have, and not like, I was really craving cake, but like you don't have enough to eat, or you don't have enough like high quality nutrient dense food over your entire pregnancy, your access to prenatal care, or any kind of medical conditions. So it's most likely if you're at one of these at-risk populations, you're going to have a low for birth weight child, or you could have a premature child. But for our African Americans and our adolescents who are experiencing pregnancy, I've linked with 2 programs. So it's the Black Infant Health Program and the San Diego Adolescent and Pregnancy and Parenting Group. And I've actually put emails as well, and you can always email me and I can give you more resources as well. But if you are in an at-risk population, either you were very young or you were African American, you should definitely check out, or you know anybody who is, you should check out both these programs because they're really working on bridging this gap of disparate healthcare access for these 2 populations, and they're fantastic programs. I actually know one of these women, and they're really making sure that all children born in San Diego County are born with the best possible healthcare so that they can grow up to be the best possible person that they can be. So this is a newborn physical. I'm not sure if it's going to let me play. So this is just what a newborn looks like. So they're typically between 5.5 to 10 pounds. They're typically 18 to 22 inches in length. They have very, very large heads, much bigger than how their body should be proportionately as adults. They have blotchy, red, white skin. It looks like it has acne all over it. They have a receding chin. I always think when my babies come out that, like, oh my God, what? They don't have a chin. But it's really, it goes down. Their profile, it's not how mine is where my chin goes out. It's really quite receding so that they can suckle so that they can breastfeed, either they can nurse on someone, or they can drink from a bottle that helps them be able to make a seal on somebody's skin while still being able to breathe. So that's why they have that restriction. They're often typically really, really hairy as well. They have hairy little backs, hairy little ears, hairy little necks. They're covered in like a white substance as well as soon as they're born, which is actually really good for their skin. You shouldn't give them a bath right away. You should kind of just rub it into their skin. It's a really good moisturizing agent, and that's why they're kind of born with it, is, you know, kind of protects the newborn as they're born. I am just going to play a little bit of this. So if you've never been around a newborn, that was my husband's. So like, he had held his nephew once, and then all of a sudden we have twins and he has no idea what to do. So if you've never been around a newborn, I'm just going to play a couple seconds of this just so you can see what they look like.
I'm going to demonstrate how to do a newborn bath with my little friends here. There are several techniques for giving a baby a sponge bath. We all agree on certain things, and one of them is that you should never leave your newborn unattended if the bath is getting started. For part of the baby, who doesn't like this? You're going to feel so good and clean. And now I can use my Pericure bottle to actually aim and squirt some water. Oh, that feels so nice, right? And I can use now my towel to dry off his hair and his face. Just give him a little rinse.
So as you can see, a very large head, a very quite long torso as well, and shorter, stubbier arms and legs. And that's really, really typical of newborns. That newborn baby actually looks really good. They don't have any of that acne that I was talking about. They're not significantly hairy as well. But they do cry a lot. And the baby was probably communicating, I'm cold, these lights are very bright, I was just in a womb and now I'm out and it's very loud and I don't like this, and please stop. So that's probably what they were trying to communicate in that moment, was, please stop babying me, I want to go to sleep. So then we also have some newborn reflexes. So reflexes are for survival. So rooting. So when a child is hungry, if you touch their cheek, they go like this. They're trying to find a nipple or a bottle in order to feed. They suck. Sucking is a reflex as well. So the ability to get nutrients from milk so that's why we suck. And then they grasp your fingers as well. I think that's a very social and emotional one. Newborns can be quite difficult. You know, they're up at all hours. They are up in the middle of the night. They're crying all the time. And I think those kind of like grabbing your fingers really kind of creates a social emotional bond with your newborn that can be really difficult in those first few weeks. Then there are some other reflexes as well, such as a moro or tonic reflex. And we don't know why they have them. It's part of our kind of lizard brain that's in the back here. It's kind of the earliest brain that we had as we were evolving into humans. We're not really sure why we have those reflexes.
Babies are born with a set of reflexes critical for survival in the outside world. Some of these reflexes are so obvious you might not think to look for them, such as the breathing reflex or the eye blink reflex. Rooting is one of the most critical reflexes. By touching 4-week-old Lily's cheek, she'll turn her head and open her mouth in preparation for nursing. Once the baby is in contact with a breast, a bottle, or even a finger, the sucking reflex takes over. Involuntary at first, the neonate will gradually gain control over sucking during the first year. Placing liquid in the mouth will induce the swallowing reflex.
In the first few weeks of life, it takes all the baby's concentration just to control these various uncoordinated reflexes. At this age, feeding Julia can take over an hour. After about 6 weeks, though, Julia will be a pro. There are other reflexes babies are born with that we don't completely understand. In the first 2 months, babies exhibit the stepping reflex. This is probably a precursor to walking. Watch Lily's toes fan out and curl. This is the Babinski reflex, which occurs when the bottom of a baby's foot is stroked.
You can also do it like this. Toes curling. Stop.
When pressure is placed on the baby's hand, you can see the grasping reflex at work. Lily's grasp is strong enough to support almost her entire body weight. For a few seconds at least. When startled or dropped, a baby may respond with the Moro reflex. The arms fling outward and inward as if the baby were groping for support. 2-month-old Julia doesn't even need to be awake to demonstrate this reflex.
So those are some of the reflexes that children might show in the first couple of weeks. And so those are really important for both for survival and being able to eat and take nutrition in. And some of them we don't know, but that's some of the behavior that you would see in the first couple of weeks of life. So some of the other behaviors, and we kind of know that they have arousal. So there's regular sleep, which is deep sleep, and that's why I have this picture of this little boy with this Santa cap on. Is like he's deep asleep. Like thunder could be going off, vacuum cleaners, he's not waking up, he is out. Then you have like a regular sleep. So if you were holding a newborn in your arms, the sound of mom talking or the lights turning on and off will make them like smile, and it's like an involuntary smile. They're not actually smiling at you. Or they can kind of jump and startle as well. And then they're kind of drowsy, their eyes are closing, they're eating. Because in the first couple weeks, babies are really, really sleepy. They're asleep more than they're awake because in general, children, when they're sleeping, that's when they're growing. So in order to grow and to develop at a really, really rapid pace that a newborn is growing at, they need to be asleep as well. And then there's this period of alert inactivity. So they're quiet, their eyes are open, and they're watching their environment. This would be a good time to put a baby down on their stomach. Since we have our safe sleep practices, we're supposed to put babies down in a hard crib on their back. That's the safest way for infants to sleep. So they need to work on their tummy time. They need to get the head control, the neck control, and be able to roll and crawl. So we need to put newborns, up to a week, kind of 2 weeks after they're born, you start putting them on their tummy so they can work on that head control and their neck control. And when they're alert and not crying or distressed, that would be the best time to put them on their tummy so they can work on those gross motor skills that they might otherwise not be having because they're on their backs or being held. So how does a newborn and their parent kind of make a bond? So for women who deliver, we know that their frontal cortex, so your ideas of the feelings and emotions that you have and where your pleasure center is located, that's lit up. So when we do brain scans of women who have just delivered, that part of their body is really kind of going haywire. We have a lot of hormonal changes and there's brain changes whenever you kind of give birth to somebody. And that is to stimulate a woman having attachment with the child, being able to nurse the child and have close contact with the child that they have delivered. We do know that for people who place their children up for adoption, they still go through hormonal and brain changes as well. And so we really need to make sure that we are nurturing and supporting women who have given up their children for adoption and help them through this kind of process. Because if they've given up the child, they're not being able to hold them close, like maybe their body and their brain wants them to, but they've given them up to kind of a home that's going to be more nurturing for that child. And so we need to support them through those processes. I do like to talk about fathers because we know that fatherhood is definitely influenced by your cultural and your time period. So, generations ago, there's kind of that stereotype of like the 1950s dad with a cigar waiting in the waiting room as his wife delivers. Now, fathers are very involved, much more involved in pregnancy and when the child is first born. And we do know that the physiology of a man as his partner goes through pregnancy or as they're getting ready for imminent fatherhood, even if they're doing it through a surrogacy or through adoption or foster care, anything like that. We know that physiology can change in preparation for that, but they need not be present at birth to form those strong bonds. So if you were deployed or you were not able to make it to the pregnancy through parts of the pregnancy and through the birth, you can still kind of set up to have positive involvement with your child when they're born. And the more involved both two parents are in their child's life experiences, the better outcomes for the child. So it need not be a mother-father. That's the traditional way, but it could be mother-mother, father-father. As long as a child has positive involvement from birth, it really sets them up for good outcomes, as long as they have a support structure around the child. So it could be grandparents, aunts, uncles. The structure matters less. The positive involvement of people in their life really matters when it comes, especially to a newborn who it really needs a lot of close attachment. I do want to talk about postpartum depression. So for people who have delivered their child, a lot of times you have the baby blues. So we're having intense hormonal fluctuations, and I had the baby blues with my third one especially. For example, I took my two oldest children to a bakery to pick out cupcakes, and this was their like big sister kind of celebration. So I was only like 5 or 6 days out from delivery, and I wanted to take my two out, celebrate them becoming big sisters. And then all of a sudden in the bakery, I just like broke down sobbing. I had a hormonal shift. I just became incredibly sad. And I was happy. I had 3 children. I was at home. I was just really enjoying the time that I was having with my little family. But my hormones just kind of made me have these hormonal shifts where I would just kind of break down and sob. But postpartum depression is not that. So it's not just kind of inexplicably feeling sad about something or dealing with the transition into having a child or having more children. It lasts a lot longer than that. It can have a depressed mood or really severe mood swings. You're excessively crying. You're having a difficulty bonding with your child. You don't want to hold the child. You don't want to be near the child. You don't seem to be happy when you're around it. You withdraw from your family or friends. They're not answering your texts or your phone calls. If you go over, they don't want to talk with you. They're really, really tired. All they want to do is sleep all day or just lay in front of the TV and watch TV. They don't have interest in pleasure and activities that you used to enjoy. It's a classic depression symptom, but more so kind of in this is you're not as involved with your child as you would expect somebody to be, or you're not involved with your partner or your family or something like that. Irritability and anger as well, with little things setting you off, the milk spills or something like that, and you're just irrationally angry about it. A big fear, and one that I've had a lot of personal experiences with cousins and family members who have gone through postpartum depression, is kind of the root of it is you feel like you're not a good mother, and so you feel like you're not bonding with the baby, and it kind of makes this whole cycle going on where you don't want to spend time with the baby, but then you feel bad about it, and it just never really kind of gets better. A lot of times people will report that they don't think clearly, they can't concentrate, they can't make decisions, they can't kind of think of more than 5 minutes out. Sometimes there can be severe anxiety and panic attacks. You think that you might drop the baby or hurt the baby. So you're just having a super anxiety about those types of things. And then there's suicidal ideation. And this is really, really, really scary. And this is the point where we really need to involve healthcare professionals immediately. So if somebody is telling you that they're having thoughts about hurting themselves or the baby, it's like an immediate call to a healthcare professional or urgent care or something like that in order to kind of get that mother and that family the support that they need in order to help with this depression. And then any kind of recurrent thoughts about death or suicide. So this is postpartum depression, and we'll talk about treatment and things like that later. I do want to talk about depression can lead to psychosis. It's really, really, really rare, but it's when you have this idea of harming yourself and others, and you go into psychosis where you think you're hearing voices or voices are telling you to hurt yourself or your child. It is rare, but I do bring it up that it's kind of the next step past postpartum depression. Those were the signs and symptoms. And postpartum depression isn't anybody's fault. It doesn't mean that you're a bad mother. It just means that you're going through some things after the birth of a child, which is a big event in anybody's life. And a lot of times it has to do with your hormones as well. The only problem with postpartum depression is if you don't go and you don't seek treatment and you just continue with feeling depressed. because a depressed parent can be less responsive to their baby's needs, and we want you to be responsive. We want you to enjoy your child so that you can set a child up for this bonding and attachment with you, so that you can be the best caregiver, so that you can support them through this early child development. So we don't want your depression to compromise the child's depression. So we want you to be able to nurture that child. And so you need to do that by getting treatment, either with meds. A lot of times you'll go on a Zoloft or something like that, so that you can regulate your moods, or you can go through group therapy or regular individual therapy at all. But the most important thing is that you involve a healthcare and mental health care professional into this treatment plan. They're the ones that can give you the medication and set you up with the therapy that you need so that you can be the best caregiver for your child. So in conclusion, birth and labor are really individual experiences that are shaped by who we are as a culture, as a race, as a group, and also by our history and where we are in history. A lot of birth complications can lead to child development milestone delays. So if a child's in the hospital a lot because they're premature or they had post-birth complications, that can affect their milestones as well. How they are with their reflexes and their newborn behaviors can be affected by the quality of caregiving that they have. So what we really need to make sure is that children have access to their postnatal well child visits to support their health and growth during this really sensitive time when they're growing exponentially, and also that we support mothers in the postpartum period. And if they're showing any signs of depression, we step in and we help them with the treatment. Thanks so much, and I'll see you guys next week.